So 43% in the proportion of overall patients who were de novo heart failure, with rates ranging from 20% in Northern America to 79% South Asia. In like pre-event study, 66% of these patients were newly diagnosed heart failure with reduced ejection fraction. So even in this group of patient, the sacubitril valsartan keep this patient out of hospital, and they help them live longer. So these patients, they have definitely significantly lower incidence of composite of cardiovascular death or heart failure rehospitalization in these de novo hospitalized heart failure with reduced ejection fraction with sacubitril valsartan. So this was the study paper in which this was transition study, in which there was initiation of sacubitril valsartan shortly after hospitalization for acutely decompensated heart failure in patients with newly diagnosed heart failure, and there they have started this sacubitril valsartan early in these group of patients. So it improves echocardiographic parameters in de novo hospitalized heart failure with reduced ejection fraction. There are changes in echocardiographic para-reversal of remodeling. Sacubitril valsartan improve cardiac remodeling and pump functions more effectively compared to ACE inhibitors ARB in de novo hospitalized heart failure with reduced ejection fraction patients. It also reduced trough concentration in de novo hospitalized heart failure ejection fraction. There is significant reduced trough concentration with sacubitril valsartan in de novo hospitalized heart failure with reduced ejection fraction patients. So a more de novo than prior heart failure with reduced ejection fraction patient achieved target dose at week 10, and fewer had leak compliance related issue, and fewer have side effect and permanent treatment discontinuation. So this is the what we can conclude from transition studies, like early intervention with sacubitril valsartan should be considered to delay disease progression in patients with de novo heart failure with reduced ejection fraction. First line initiation of sacubitril valsartan in de novo heart failure with reduced ejection fraction alongside the initiation of other guideline directed therapies is feasible and is associated with better risk benefit profile than in patients with prior heart failure with reduced ejection fraction. So like 2021 update to the 2017 ACC expert consensus decision pathway for optimization of heart failure treatment. So this is the usual treatment algorithm that which shows that ARNI is preferred choice as a foundational therapy along with beta blockers and diuretics. And because of newer evidence, ARNI is now also recommended in newly diagnosed ACB, ACE inhibitors, ARB naïve patient. Like until unless it is like contraindicated in almost across all class of heart failure with reduced ejection fraction, these ARNIs is the preferred drug of choice. Now, the main aim of clinician, it should be to achieve optimal guideline-directed medical therapy within 3 to 6 months of an initial diagnosis of heart failure. So, what we can conclude is ARNIs may be considered as a first-line therapy instead of ACE inhibitors in heart failure with reduced ejection fraction.